Rheumatic fever. Etiology, pathophysiology, and pathology. Rheumatic fever results from an abnormal immune response to pharyngeal infection with group A beta hemolytic streptococci. There is evidence of a genetic predisposition with specific B-cell antibody D8/17 in over 90% of patients, and linkage with HLA-DR1, DR2, DR3, and DR4. Characteristic perivascular. Ascoff's nodules have a widespread distribution in the connective tissues of joints, tendons, and blood vessels. Apancarditis may develop, with endocardial inflammation affecting valve leaflets, chordae tendineae and papillary muscles. Fusion of leaflets and chordae leads most commonly to mitral stenosis, which is worsened further by the progressive fibrosis and eventual calcification that occur after the acute episode. Mitral regurgitation may occur and tricuspid involvement is seen in 10% of rheumatic fever cases. Aortic valve involvement more commonly leads to aortic regurgitation. Epidemiology. Rheumatic fever is rare in developed countries, with an incidence of less than 5 per 100,000 per year, usually between the ages of 4 and 18. Clinical presentation, physical signs, and investigations. See Table 36. Blood cultures. These help to exclude infective endocarditis, i.e. blood tests. Look for the following: anemia and leukocytosis, elevated ESR and CRP, streptococcal serology. ECG. Normal. May show prolonged PR interval. Chest radiograph. This is either normal or shows cardiomegaly, pericardial effusion, pulmonary edema, or increased pulmonary vascularity. Echocardiography. Echocardiography helps to exclude i.e. valvular abnormalities, myocardial dysfunction, pericarditis and pericardial effusion. NB. Consider the following in your differential diagnosis, i.e. viral infection with or without congenital cardiac abnormality, non-rheumatic acute streptococcal infections, juvenile chronic arthritis, systemic lupus erythematosus, traumatic or septic arthritis, gout. Treatment. Emergency. Treat heart failure. Severe valve lesions with deteriorating cardiac function may require valve replacement in rare instances. Short-term. Bed rest eases joint pains. A day course of oral or intramuscular penicillin, erythromycin in allergic patients, will eradicate the organism. Treatment with salicylates or steroids is symptomatic and does not affect the outcome. Long-term. Duration of anti-inflammatory therapy varies from 1 month in mild cases to 2 to 3 months in more severe ones. Taper steroid therapy at the end of the course with the substitution of aspirin to reduce rebound inflammation. Prognosis. Joint pain and fever usually settle within 2 weeks. The risk of residual heart disease increases with the severity of the initial carditis, as does the risk of further damage during any rheumatic recurrence.